So hi, everyone. Thanks for joining us today. Myself and my colleague, Dr. Linda Boiij, are going to be presenting to you how a large-scale eating disorders program was adapted to virtual means at the beginning of the COVID-19 pandemic. So we're going to be talking to you about what this program looked like before COVID, how the adaptations were made, and also about some challenges that we faced in adapting this large-scale program to virtual means. We're also going to be talking to you or presenting to you some outcome data that we have looking at whether this new virtual program was effective in helping individuals with eating disorders get better, recover, reduce their symptoms, and also how the patients that we treated perceived the program and how they benefited from it and their satisfaction levels overall with this new type of program. So my name is Dr. Lea Thaler. I'm from the Eating Disorders Continuum at the Douglas University in Montreal, Quebec. And my colleague, Dr. Linda Boiij, is also from the Eating Disorders Continuum and also at Concordia University in Montreal. So to tell you a little bit about our program. So like I mentioned, we are a large-scale, publicly funded eating disorders program established in 1986. And we're actually the largest program in the entire province of Quebec in Canada for adults with eating disorders. We serve individuals that suffer from anorexia, bulimia, so the AN is anorexia nervosa, BN is bulimia nervosa, OSFED are the other eating disorders that are similar usually to AN and BN, but tend to fall into the other category, as well as ARFID, avoidant restrictive food intake disorder. I mentioned that we are the largest program in the province for adults, and we also more recently have began serving adolescents as well. And because we are one of the only publicly funded programs in the province, we do have what we call a province-wide mandate. So individuals will come to us from all over the province of Quebec, from the region of Montreal, which is where we're located, but also from areas that are further away. And sometimes before COVID would have to travel quite long distances to either attend our outpatient program or our day treatment program. We provide treatment based on evidence-based approaches, which I'll talk about in a second. We also do a lot of clinical research, and I won't go into all of our different research projects, but we do a lot of outcome research looking at outcomes in our different programs. We also have a really large scale epigenetic study looking at the epigenetics of anorexia nervosa, and we've done a lot of genetic and epigenetic research in the past. We are also a center for teaching and training. So at any given time, we usually have between 2 and 6 clinical psychology or counseling psychology students, as well as students in social work, nutrition, nursing, psychoeducation. And we also provide teaching and training on eating disorders to universities and to other mental health teams in the region. And this is related to our large-scale knowledge transfer program, which I'll come back to in a second, where because we have a province-wide mandate, we basically wanted to try and provide services for patients that would live or are living quite far away from where we are. So we have been involved in training lots of different mental health teams all over the province to be able to provide the kind of treatment that we provide. So we use what we call a sequential model of treatment, starting at lower levels of intensity, evaluation, outpatient types of therapy. And then we have more intensive treatments, such as a day program or day hospital, as well as inpatient admissions. And so basically, when patients first come to us, a lot of them will start at our outpatient level, but they can step up care as needed, as they need more intensity, and then also have the option to step down so that they have a transition of services and go from something, let's say, more intensive to something less intensive. As I sort of mentioned, we have a large multidisciplinary team in our clinic. So we have, like I mentioned, psychologists, as well as psychiatrists, nurses, social workers, psychotherapists, nutritionists, psychoeducators, and students. As I mentioned, this is just a kind of model of our large-scale knowledge transfer program. So like I said, we have trained lots of different mental health or healthcare teams all over the province. This is a map of the province of Quebec. And CSSS stands for those teams. It's the acronym or the abbreviation that we used to use in the province to refer to kind of local healthcare units. And so the idea was that we could train these teams to provide these kind of initial levels of treatment or services, the kind of less intensive evaluation and doing, let's say, individual outpatient psychotherapy, sometimes outpatient group psychotherapy. And that then patients, if they needed to do something more intensive, could come to us. And the idea was that oftentimes individuals would wait less time to be seen by somebody in their sector or their location, as opposed to waiting on our waiting list, which was quite long. So just briefly, types of outpatient treatments that we offer. So these are all evidence-based treatments for eating disorders. So our outpatient and day treatment is really heavily based on cognitive behavioral therapy, which is really the gold standard treatment for bulimia, binge eating disorder, OSFED, and also for anorexia for adults. For adolescents, we try to, when possible and when indicated, provide family-based therapy, which is the evidence, one of the evidence-based approaches, and also the gold standard for adolescents with anorexia, also for adolescents with bulimia. We have therapists that are highly trained in dialectical behavior therapy as well. And so we use that usually as an adjunct for bulimia, binge eating disorder, but also for anorexia. And we really do, we use an integrative approach where we're often combining cognitive behavioral therapy, dialectical behavior therapy, motivational approaches, and some other approaches as well. So most of our clinicians would describe themselves as using an integrative approach, but that's based on evidence-based approaches. In addition to the specific types of theoretical orientations or models that we use, we have kind of a general clinical approach that's really focused on autonomy support and helping individuals move towards a place of more autonomous motivation, meaning that they're able to kind of see that the reasons that they want to change and the reasons that they would want to recover from their eating disorder, that's coming more from internal reasons as opposed to external or coercive approaches or reasons. Obviously, with this, we always need to ensure somebody's safety. So it's not that we let people just do whatever they want if there's issues of safety. But we really want to help our patients really evaluate their choices and their values. And we have, a lot of emphasis on tolerance of individuals' struggle to change and the time it takes to achieve it, that it can take a long time and it might not be in one given outpatient treatment that they are enrolled in, that's when they might make all of the changes that they would possibly make. And it might take more than one treatment. And we're aware of that. And we try to be patient and really work with individuals where they're at. So meeting them really where they're at and trying to help them make small or larger changes based on kind of their stage. And our approach is also really based on helping patients encourage experimentation with behaviors that really put mistaken beliefs to the test. This is really one of the hallmarks of CBT. It's really helping patients kind of answer the question of, this behavior that you're engaging in, is this really in your best interest? So now to talk about what happened when the COVID-19 pandemic hit. As for pretty much everybody in the world, in North America, but all over, it was, one day to the next, everything just kind of changed. We were, told to not see patients in person anymore, to not run in-person groups. And so very quickly we had to figure out, okay, how can we still provide services to our patients, given that we have a large mandate? A lot of patients are seen in our clinic at once, or usually around 200. How can we still provide services for these patients without leaving them kind of hanging? And to say that we adapted our program to virtual means relatively quickly. Within, I would say, the span of about 2 to 3 weeks, we were up and running virtual groups and doing virtual sessions with our patients. So as we kind of even knew before the pandemic, teletherapy or virtual therapy offers opportunities for increased access and continuity of services for patients through interventions that are usually conducted via phone or computer. And again, since the beginning of the pandemic, many programs and services have had to adapt their practices to virtual methods. We didn't really have much of a choice. So how did we do this? How did we go from running everything in person to pretty much everything virtually? So like I said, we had to transition to 100% virtual therapy because pretty much at the start, the directives of our institution, of our provincial government were to limit any in-person contact. So we began using Zoom and then later on Teams a bit more to continue services that we had already started offering patients. So we quickly were able to help patients and our staff as well figure out how to use Zoom to do individual therapy as well as groups therapy. So we have both outpatient groups that run once a week and then a day program that was running 4 days a week from 9:30 to 3:30 that serves 15 patients at once. And so we had to adapt our day program as well because these are patients that need, as I mentioned before, more intensive services and more care. And so we really didn't want to leave them without any sort of support. We also had to adapt certain other parts of our daily functioning, such as our multidisciplinary team meetings, supervisions, and teachings to be all online. Just to mention that our inpatient unit, we have a very small inpatient unit of 6 beds, and that remained obviously in person during the pandemic. But there were slight changes that were made there as well in terms of patients weren't allowed to have visitors anymore. They weren't allowed to go on passes or outings as they were before. And so we had to make some changes there as well. So how do we prepare patients for virtual therapy? First thing is that obviously patients had to have the equipment necessary. Luckily, a lot of our patients already did. Most of them already had a cell phone or a tablet or a computer. And obviously they would need to have some type of high-speed internet access, which again, a lot of them already did. For patients that didn't, we still offered, or we did offer and still do, phone sessions. Some patients needed to do so because they didn't have good enough for high-speed internet access. Some preferred it at the beginning. They were a little bit shy to kind of start doing virtual, video sessions. We would tell patients, or the staff as well, that a laptop or a desktop with a wired connection is really the best option. And so for most of our patients, that's not necessarily what they had. But for us on our end, we quickly were able to secure extra technology that we needed in terms of laptops and tablets also, but really preferring laptops with a wired connection or a desktop with a wired connection, especially when conducting group therapy, because on a desktop or on a laptop screen, you can actually see more participants at once. On a tablet, such as an iPad or on a phone, it's harder to see an entire group of people, especially if you have, 10, 15 people all at once. The other thing that we had to contend with, which was quite different from before, were issues of confidentiality. So before, patients would come to our clinic, sit in our office, sit in our group room, and it was a given that nobody was there listening outside our doors, and that obviously was just patients knew they had to keep whatever was discussed in group therapy confidential in terms of not then going and talking about it with other people. But now we're doing therapy with people in their own homes, which is very different. So we had to make sure, we had to remind patients, and we still do a year later, that it's necessary to have a closed or private space where they can be alone. And if they can't, that they're really advised to use headphones when they're not alone. So this is to protect their confidentiality when they're doing individual sessions, and especially when they're doing group sessions, it's also to protect the confidentiality of everybody else in the group. So this is just an example of the kind of document that we would send out, or still do send out, prior to starting, let's say, an outpatient psychotherapy group. So it gives information about, we're doing it using virtual platforms, the schedule, duration, the start date. This would all be on one document, but I had to put it on different slides for this purpose. And then there's certain things that we wanted to communicate to patients, some of which was the same as when we were running in-person groups. So asking them to arrive on time, asking them to not have more than a certain number of absences. The things that I mentioned in relation to confidentiality are written down. Asking them that also that they have a camera that's functioning on their device and that they keep it open. So opening the camera is mandatory. We don't want patients basically participating with their camera closed. Really for a variety of reasons, and also to promote cohesion in the group. We ask them to mute themselves when they're not speaking, just to limit kind of any background noise. And this is a bit small, but then we talk about some limits of remote treatment in terms of, just ethical considerations, that we're asking patients also to consent to participate in teletherapy. And so they're providing informed consent. They're aware that there's obviously always limitations to the confidentiality of any communications that are being made via the internet, although we've had no issues to our knowledge with anything related to that. We are still using the highly secured version of Zoom, not the regular, free one. We also remind them, even though it's disabled on our versions of Zoom, that they cannot record the sessions. And then we have them read this and then sign it before they start a group psychotherapy or even an individual one as well. So to talk about some of the challenges we faced, I made it sound like this was all nice and easy. And I think we did a good job of transitioning quickly, but we really had to learn a lot along the way. Those first few months, even the first 4 or 5 months, we were, making tweaks and adapting and figuring out how things are going to work. So first figuring out are we keeping the length of treatment that we offer the same? So what we offer is really, for an outpatient treatment, we offer 2 blocks of a 10-week outpatient group therapy. So it's about 20 weeks that patients get, plus a little bit more usually. So in total, they're usually getting between 20 and 30 weeks of outpatient therapy. If they do something more intensive like our day program, it was 12 or 16 weeks, depending on whether they had to gain weight. Patients that needed to gain weight, we gave them a bit more time, so we gave them 16 weeks. So we had to figure out, do we keep those time limits the same? Do we not? We opted for our outpatient treatment to keep it the same. For our day treatment, we actually were giving everybody 12 weeks to start because we were concerned about patients just not having access, and we wanted to be able to get patients in more quickly. But then recently now, we started offering 16 weeks to anybody who wants it, even if they didn't have to gain weight. So sorry, initially we were offering the 12 or 16 weeks in the same way as we had before. Now, because it's less intensive, we're actually offering 16 weeks to anybody who would want, even if beforehand they would have only been given 12 weeks based on their weight. Number of groups per day. So this is really pertinent to our day program. We started out, we were testing out to see if we could offer 2 groups a day plus a meal support. We ended up doing 1 group, so one kind of skills-based education group in the morning, and then 1 meal support, and then an optional meal support at dinner. So the mandatory meal support is at lunch, the optional one is at dinner. Initially, we thought maybe we could offer 2 skills-based groups during the day just to kind of provide more intensity. It wasn't feasible for a variety of reasons. And in the end, patients were, okay with having the 1 group for an hour in the morning and then the meal support. We also had to face the limitations to meal support. So anybody who's done this virtually and in person can attest to the fact that it's very different. In person, in our day program, we were cooking with patients. We were cooking pretty much all of the lunch meals we had there and then eating together. And so, the meals were predetermined and the patients didn't really get a choice in what they were eating. Now doing it virtually, patients prepare their own meals. There's guidelines of what constitutes, a proper meal, but they can choose, what they want to eat. And everybody's then also eating different things. We can't see in the same way. If somebody is completing their meal, there's a lot more autonomy and a lot more trust placed on the patients that, if they want to hide food, they can. And we kind of understand that that might be tempting and we work with them, but we understand that that's just a limitation of doing it virtually. Also individual therapy. So at one point last summer, we were then allowed to start seeing some patients in person again. And so trying to figure out just how to combine that. Are there patients that are only going to come in person because they don't like the virtual sessions? Do we offer some combination where some of them come in sometimes and some do virtual sessions sometimes, which is kind of what a lot of the time we ended up doing. And then training opportunities for students. So we really weren't sure at first if we could still offer the same training opportunity. Luckily, we were able to. So last summer and then this whole year, and now currently again in the summer, we have practicum students and interns. And even though they're doing pretty much everything virtually, they're getting a lot of the same clinical training and experience. So that was also just an adjustment as well. Other common challenges that we faced in doing virtual therapy for eating disorders, or just some of this is doing virtual therapy in general, was how do we monitor patients' weight? So if they're not coming in beforehand, they would come in for an individual session and we would weigh them as per CBT protocols and other protocols that always usually suggest that that's a good way to do it. So here we had to figure out, are patients going to weigh themselves and just report to us? Can they do it on camera? Sometimes that's possible. Some of them didn't have scales at home and didn't want to have to buy a scale because that was something that would be difficult. There was a reason that they didn't have a scale in their house. So trying to navigate that and figuring out what would be the best option. And we didn't come up with kind of any one solution. We tried to use an individualized approach where we would figure out what would be best for that particular person in this particular context right now, and then work with them and then make adjustments. For example, if a patient said, I'm going to weigh myself and report it to you, we would try that, but then we would check in and say, are you being fully honest? Is there any temptation to not be honest? Usually in an outpatient context, there isn't, because we don't really have consequences for if they gain or lose weight. In our day program context, where we're still asking people, we still have weight gain contracts, of course, there's more temptation maybe to not be honest, but we always just work with patients and they tend, we think, to be honest with us, that if they're not able to weigh themselves and just report it, then we'll figure out a different way, doing it on the camera or having them come in once in a while. The other thing that tends to come up more so in groups than individually, just as you can imagine, is, patients are at home and so they're doing other things while they're in therapy. For example, laundry, household chores, even just walking around their house, which can be quite distracting for them because they're probably not paying attention, but also for the other people watching. And so this is just things that we remind them to try and not do. It's in the guidelines that I showed you before, but we also just try to talk about, why this is maybe not helpful for them and also not helpful for other people. Turning off their cameras or leaving screen, again, more so in the context of group therapy, because when you're one-on-one with somebody, their chances are they're not going to turn off their camera while they're talking directly to you. Or lying down. So that's a new thing, is that when we see people individually or in a group in our offices, we have chairs or maybe couches, but people are not lying down in their bed. Now I do a lot of therapy with people lying down in their bed. And again, we don't have strong rules about this. It's more just to see that, is the person still able to engage in the therapeutic process if, they're in a kind of different physical position or physical environment. And again, if we're talking individually, we can talk to patients about this and say, hey, I see you're in your bed. Are you more comfortable that way? Are you able to still kind of really, put in, the mental effort and work into our session? And if they say yes, then we can let them do that. Just a note on breakout rooms. So in Zoom and I think in Teams, although personally I've never used it in Teams, we found that sometimes it's helpful. So in our outpatient groups and our day program groups, we often have about 15 patients at once. And so we found that, again, this was true for in-person therapy as well. But we found especially just, using virtual platforms, sometimes it was a bit harder for patients to really connect with each other and exchange or feel like they could take their place in the group because there's that awkwardness of like, who's going to speak next? And, you know, a lot of the nonverbal cues that we have in person are a little bit less apparent. So we found that using breakout rooms, which is where you divide, let's say, a larger group into smaller groups, really helped with patients participating more, opening up, you know, connecting with each other. So just to say that, obviously what we realize is that you would need, if you're going to do breakout rooms, ideally each one is being monitored by a therapist or by a student co-therapist, just to facilitate discussion and ensure any type of safety. And we've often found it's useful to have like predetermined exercises or discussion topics for these breakout rooms to really help facilitate, like I said, discussion, participation, exchange. And we're able to do this because in most of our outpatient or day program groups, we have students. So we train the students pretty quickly, and then we can have up to 2 or 3 smaller breakout rooms staffed by a therapist and then by a student or 2, depending on how many are there. And so now we're going to transition to talking about some of our outcome findings. I'm going to hand it over to my colleague, Dr. Linda Boiij.
How does virtual therapy for eating disorders work? Are the effects similar or different than what you would see after face-to-face outpatient treatment? We now present the first results of a research project that evaluated the efficacy and satisfaction of the remote virtual services offered in our clinic during the current pandemic times. Specific aims of this research project were to study whether 10 weeks of virtual therapy reduced symptoms, and we also studied whether or not there are differences in efficacy compared to face-to-face therapy. We also studied whether people that took part in our virtual therapy program were satisfied with the services they got, and from their perspective, what the challenges, limitations, and advantages were. So in this table, you see some of the characteristics of the people who took part in our study. The face-to-face group consisted of about 100 people who had complete data and completed at least 10 weeks of therapy face-to-face prior to the pandemic. The distance therapy group consisted of approximately 50 people who also had complete data and completed at least 10 weeks of therapy, but then using our virtual services during the pandemic. About 40% of the people who participated had a form of an eating disorder that included dieting, fasting, and/or excessive exercise, but without any form of binge eating or purging behavior. And approximately 60% of the participants had an eating disorder that included recurrent episodes of binging or purging. The average BMI, body mass index, is approximately 20 across the different diagnoses. And both groups had significant levels of eating disorder symptoms, as shown by the EDEQ score. As commonly seen in people with eating disorders, the people who took part in our study had moderate levels of depressive symptoms, as well as moderate levels of anxiety levels. And this was seen on the scores on the PHQ-9 and the GAD-7 questionnaire. And these moderate levels of depression and anxiety symptoms was seen in people who had received the face-to-face treatment, as well as in those who received distance therapy. In this graph, you see the effects of 10 weeks of face-to-face treatment compared to 10 weeks of distance therapy on eating disorder symptom severity. So the red bars reflect eating disorder severity levels before starting therapy, and the green bars reflect the eating disorder severity after 10 weeks of therapy. On the left, you see the symptoms during the usual face-to-face treatment, and on the right, these 2 bars reflect the symptoms during distance therapy. Both face-to-face and distance therapy led to a decrease in eating disorder symptoms after 10 weeks of therapy. Interestingly, the change is very similar in those who received face-to-face treatment relative to those who received distance therapy. So it seems that both forms of treatment, whether offered face-to-face or through telehealth, is equally effective in treating eating disorder symptoms. In this effect, so the decrease in eating disorder symptoms, but no difference in whether treatment is offered face-to-face or virtually, is seen on all of the 4 subscales of the EDEQ. So this includes a reduction in dietary restraint, a reduction in eating concerns, as well as reductions in concerns about shape and about weight. Here you see results on body mass index. And for this comparison, we limited ourselves to those people who had a body mass index lower than 17.5. And that mostly is in people with anorexia nervosa in our research group. We saw that after 10 weeks of treatment, the body mass index increased in people who were considerably underweight at baseline prior to the start of therapy. By comparing the graphs on the left with those on the right, you see that the change in BMI was similar for people who had received face-to-face treatment to those who have received remote distance therapy. Let's now have a look at depression symptoms. So symptoms of depression are very common in people with eating disorders, and thus are important to evaluate. Notably, people who received distance therapy tended to have higher levels of depressive symptoms, both when they started their treatment as well as after 10 weeks of treatment, compared to those who received face-to-face treatment. Since distance therapy was offered during the pandemic may be the cause of the higher levels of depressive symptoms that we saw in our patients at baseline prior to the start of treatment and after 10 weeks of treatment. What is also of interest here is that you see that the change in symptoms is different for those who received face-to-face treatment prior to the pandemic to those who received distance therapy during the pandemic. Specifically, during face-to-face treatment, depression levels tend to go down. During the distance therapy amidst the pandemic, depressive symptoms are slightly going up, and this may suggest that the treatment is not sufficient to cope with pandemic in terms of mood. A somewhat similar pattern was seen for anxiety levels. Overall, people who received distance therapy during the pandemic tended to have higher levels of anxiety, both when they started their treatment as well as after 10 weeks of treatment. While not statistically significant, here you see as well that anxiety levels tend to decrease during face-to-face treatment, and there's no change or even a slight non-significant increase in anxiety levels during distance therapy. How satisfied are patients with our distance therapy services? We administered an 8-item questionnaire that is items about whether the services met their needs, if they would recommend the service to a friend who would have an eating disorder, if the services help to deal with their problems, and the overall quality of the services. And on the graph here, you see the mean score on this questionnaire, with the green bar reflecting the level of satisfaction with face-to-face services, and the purple bar on the right reflecting satisfaction with our virtual distance therapy services. Overall, this graph showed that people were mostly satisfied to very satisfied with our services. And the level of satisfaction was very similar for the services offered virtually and the usual face-to-face treatment. Since we started distance therapy, we also started to ask people to fill out an additional questionnaire. This questionnaire has more specific questions about people's experiences with the virtual services of our program, the challenges that they may encounter, and what they liked about it. And this is all rated on a 5-point scale. In terms of overall quality, people rated the telehealth services provided during the pandemic satisfactory to very good, both for the individual sessions and for the group sessions that were offered virtually. We also asked people whether they think virtual distance therapy is better than in-person therapy, whether it's as good as in-person, or whether it's not as good as in-person. And we found that patients tend to perceive our virtual services as slightly less good as in-person face-to-face therapy. Some of our people in the virtual program made use of our face-to-face therapy services in the past. And these individuals were just able to make a direct comparison between the two types of services. So based on their previous experiences with face-to-face outpatient treatment, the returning individuals also perceived distance therapy as slightly less good than face-to-face treatment. Here you see in greater detail how patients rated on a 5-point scale the different potential challenges, the limitations, and as well as the advantages that may come with virtual therapy services. The bars in green represent positively framed items. So the highest score is more satisfied, rated on a 5-point scale. And the bars in pink represent negatively framed items. So a lower score is more satisfied, also on a 5-point scale. Note here that people who participated in the virtual program, as seen in the bars in green, appreciated the flexibility, liked that they didn't have to commute and thus save time, valued the improved access to services, and they also were confident that the help is there in emergency situation, even though when there's no face-to-face interaction with the therapist. The bars in pink showed that there's not much concern about confidentiality among patients. And generally, patients don't think telehealth did impacted their ability to express themselves, to emotionally connect, or to read therapists' nonverbal language, nor did they feel that the lack of in-person treatment had negatively influences on their actual treatment. But to summarize, we showed that our virtual program was effective for treatment of eating disorder symptoms, and that it was equally effective to face-to-face treatment in terms of reducing eating disorder symptoms. The pandemic has created additional challenges for people with eating disorders, including overall higher levels of depression and anxiety before and during treatments relative to pre-pandemic times. During the pandemic, the virtual services did not lead to the expected decreases in depression and anxiety. And this suggests that depression and anxiety symptoms in people with eating disorders may warrant additional monitoring and intervention during pandemic times. Overall, people were satisfied with the quality of the virtual services. They appreciated the convenience and the acceptability in particular, and there wasn't not much of a concern about confidentiality. Overall, they felt that the lack of in-person interactions did not have any negative impact on their actual treatment. However, patients perceived telehealth not as good compared to our in-person, face-to-face specialized services for eating disorders. And this confirms that while virtual distance therapy has many benefits, it cannot fully replace our in-person, outpatient specialized treatment for eating disorders. Given these first experiences with virtual treatment in a specialized eating disorder program, an important next step will be to further determine what aspects of telehealth services would be good to maintain once the pandemic is over. This was the end of our presentation, and we would like to thank our colleagues of the Eating Disorders Continuum, Dr. Howard Steiger, head of the program, the research assistants and students who were of much help in getting the data together to evaluate our services, the therapists of the eating disorder program, and as well the individuals with eating disorders who participated in our study. Thank you.